So just to introduce Dr. Chris Hayes, Chris is a pain medicine physician heading up the Hunter New England multidisciplinary pain unit in Newcastle, Australia. Chris is the immediate past Dean of the Faculty of Pain Medicine, Australian and New Zealand College of Anaesthetists. And Chris is also known to you because he straddles the ditches, I've heard it mentioned during this Congress, in his professional and personal experience. And Chris has been a real thought leader in Australia and someone I ring often for advice to discuss things. Welcome, Chris.
I'm from Newcastle, Australia. The slide on the right shows Newcastle, iconic leading coal export port, and a particular day in 2007 when the Pasha bulk was washed up on our shores of Nobby's Beach. I'm comparing that on the other side of the screen with a series of beautiful slides from the Tarkine Wilderness in Tasmania, a recent ultra run that I indulged in, partly because I think Adrian and his work in Tasmania establishes them as world leaders in what we need to change in the opioid epidemic. I think the coal industry, like the opioid industry, needs to get smaller, particularly in regard to chronic non-cancer pain. On the other hand, you could say that our focus on the environment and sustainability needs to get bigger. These are my disclosures. I did do some work for various pharmaceutical companies before I thought better of that in 2013. I work in the public hospital system in Newcastle, and our pain service there has put on its website various documents, including reconsidering opioid therapy, which gives you an idea of my perspective, and also our team has designed a Brain Man cartoon series to illustrate various points, such as Brain Man stopping his opioids. As Adrian has mentioned, I've had a role in various other organisations, particularly linking to opioid strategy. As I go through today, I'm going to touch on these issues. What models of care do we have available and what might need to change? If you were at the previous session on medically unexplained symptoms, you will note a large degree of overlap. And I think also, as Adrian has mentioned, the first 1,000 days of life equally intersect with this space. I'll talk briefly about the evidence, why we spin off that to think that change is a good idea, comment briefly on some guidelines, and then look from my own team's perspective in Newcastle at some of the challenges around implementing new strategy. Then I'll talk a little about advocacy and where we're up to in Australia and the role of regulation. The biopsychosocial model you'll be familiar with. Confessions from the pain sector is that we have often paid lip service to the biopsychosocial while continuing to give the bio precedence. So out of that thinking has been the thought that we should invert the biopsychosocial and give a socio-psycho-biomedical approach. Quite hard to say after a glass of wine on a Friday night and difficult to use in front of a patient. You're not going to say you'll do a psycho-socio-biomedical approach to them. So hence, from our team's perspective, we've gone in a health literacy appropriate way to talk about a whole person approach and those 5 fingers mentioned on screen. So moving past the thumb, the biomedical, to look at mind-body connection, activity, and nutrition aspects. Another point of change worth mentioning comes from the IASP Taxonomy Committee and the word nociplastic, which is, again, a bit tricky to remember, I think in some ways has filled a void. We've often noticed in treating patients in a tertiary pain clinic that many of them don't have an active nociceptive component nor a clear neuropathic nerve injury component to their pain. So most of what we've been treating relates to sensitization in the nervous system, and the nociplastic word to some extent fills a diagnostic void. Most of the people we're treating in a tertiary pain clinic have nociplastic related pain. With overlap in the previous session, acknowledged a somatic symptom disorder. I think in terms of models of change, Susan Michi's behaviour change wheel is important. This is, I think, a significant improvement on the stages of change model that talked about whether someone was pre-contemplative or contemplative. In that previous model, if someone is pre-contemplative, it leaves you fairly disempowered. What are you going to do to bring about change? This model, on the other hand, is empowering, although the patient, represented by the green inner circle, may have limited capacity, opportunity, or motivation to change. There is still much that can be done by the clinician, represented by the red circle outside, and you can see various opportunities there to persuade, to coerce, to enable, to restrict, etc. And then beyond that, again, the policy categories in the grey outer circle are influential, most influential, I think, the guidelines, the legislation, and the regulation. I know in Australia, we began to buckle up our seatbelts when the law told us that we would get in trouble if we were to do otherwise. What evidence is there that we need to change our opioid strategy? For some time, we've had available many short-term trials, 8 to 12 weeks in duration, that show a modest treatment benefit if you are to give opioids to a population with chronic non-cancer pain. There has been a lack of long-term studies, and it would seem unreasonable to extrapolate from an 8 to 12-week study into chronic non-cancer pain. So 2 studies to mention, both from 2018. This is the SPACE study, so-called, from Erin Krebs and colleagues. It was a pragmatic randomised controlled trial, meaning that it was non-blinded, and it was of 1-year duration in a primary care setting. They took Veterans Affairs patients with chronic back pain or knee or hip-associated osteoarthritis not on opioids, and they put them into either A, an opioid pathway, or B, a non-opioid pathway. No differences in mean pain intensity at outset, and they tracked them for a year, showing that the pain scores were worse in the opioid group, the pain interference was no different between groups, and the adverse effects worse in the opioid group. So this is the plotted outcomes there. You can see that pain severity did reduce over the course of the 12 months, but more so in the non-opioid group. Second influential study from 2018, again from the States, again Veterans Affairs, looked at opioid discontinuation. They looked at 500 odd patients who had been on opioids for at least 12 months before discontinuing. And that's the distribution there on the bottom dot points, most with what was labelled musculoskeletal pain, some with headaches and neuropathic pain as well. And this might be a little bit hard to read, but you can see in the discontinuation slide, the mean pain intensity was 4.8 on a 0 to 10 scale, which dropped slightly post-discontinuation. So their conclusion was when you stop patients who've been maintained on opioids, that their pain scores either don't change or change minimally, and that's even in the absence of any other active pain management treatment. Guidelines, Adrian has mentioned a little. In both Australia and the US, we do have some guidelines that are tending to discourage opioids, but not actually rule against it. So I have had roles within the Faculty of Pain Medicine at the College of Anaesthetists. I feel a little dissatisfied with guidelines. They do highlight traffic lights around harm at 40 milligrams and 100 milligrams of morphine equivalent, but then we say in that, given the widespread prescription, the following principles are offered, and we talk about ways to support that practice. The US Centers for Disease Control have a similar guideline. They have their traffic lights set at 50 and 90 milligrams of morphine, but then they go on to say, in a disempowering way, I believe, consider opioids only if expected benefits outweigh the risks, which of course lets any clinician off the hook. I always expect that the benefits of my patients will outweigh the risks, so I continue to prescribe opioids. Compare that to the NICE guidelines in the UK 2016 for low back pain and sciatica that say simply do not offer opioids for chronic low back pain, which I think is more where we should be moving to. How do we implement? And these are comments from my own team. Interestingly, enjoyable, I think, to work in a small team setting as opposed to the broader consensus politics of being part of ANSCA and developing guidelines at that level. We would say from our team's perspective that the opioid indications are these: acute pain, cancer pain, palliative care, and opioid dependency, supported by systematic reviews and randomised controlled trials. You can see chronic non-cancer pain is not on that list. However, there is a grey zone around this, zones of clinical uncertainty around each of those categories that are well supported by the evidence. So yes, in acute pain, how long should we go on for in terms of opioid duration of therapy? Officially, it becomes chronic pain after 3 months. So yes, in a complex case, there may be value in cautiously continuing beyond the 3-month mark. There's a grey zone in cancer survival when someone who is given evidence-based opioids for cancer pain becomes a survivor. We need to look at how long the opioids go on for before we wind them back. In the palliative care zone, there's clearly a grey area between an older person who may not benefit from opioids and an older person transitioning into palliative care who would have evidence-based benefit. And again, an overlap zone between addiction and pain. These are the zones of uncertainty. Otherwise, if people are not in those zones, I think we can say that opioids are no longer indicated for chronic non-cancer pain. Our first dot point there. Other recommendations: have a conversation about opioid weaning. This begins to shift the focus. And negotiate with the patient around rate of reduction. Would you prefer a fast or a slow wean? Would you like to have celery or carrots with your lunch? Our standard approach is to have a monthly step down in dose. This is often a recommendation going from us to the GP, step down by 10 to 25% each month. That's the standard, which obviously implies there are many non-standard approaches. You can speed up or slow down as required. How are we going as a team with these policies in place? You could say that we're doing well if in reducing opioids we're seeing patients make functional gains. On the other hand, we might be seen to be doing poorly if we reduced opioid dose and saw people's quality of life and function deteriorating. These next couple of slides are from our EPOC annual benchmarking report, Electronic Persistent Pain Outcomes Collaboration, now with 80 sites participating across Australia and New Zealand. You can see here that the average oral morphine equivalent dose from referral to episode end is approximately halved. Episode end is about 3 months later in EPOC speak. So it's a reasonable change in a 3-month time frame. So we are successfully reducing opioid dose. And this summary slide as well, comparing our Hunter Integrated Pain Service with the all-service average, shows that while we are reducing opioids, many patients, often up in the 50 to 60%, are making significant improvements in other key domains. So quality of life is improving alongside opioid reduction. That's talking about implementation at a tertiary public hospital pain service. We are spoiled in some ways with a multidisciplinary team there and avoiding many of the difficulties inherent in private practice and in primary care. So with my GP colleague and addiction medicine specialist Simon Holliday, we have written last year and published an article called Prescribing Wellness, Comprehensive Pain Management Outside Specialist Services, which taps into the key zone of what can the GP do and others in a primary care setting. Just making the point that it is possible with short serial interactions at general practice to make progress. We can do things differently in a tertiary centre where we have longer appointment times but over a shorter period. General practice can chip away provided the vision is in the right place with short interventions over a long period of time. Advocacy, just a couple of comments about this, and I'm getting towards the end. What's happening in Australia at the moment? In 2010, many of us gathered in Parliament House in Canberra to advocate for and establish the National Pain Strategy. These were the goals of that strategy. Interestingly, though, although we highlighted pain as a big problem, our politicians and our health bureaucrats were unable to deliver too much meaningful change after that. Just seeing that there is a big problem doesn't necessarily lead one to think about solutions. So since then, we've been working with the aid of Pain Australia, our lead advocacy body, in trying to implement change in an interesting way. A couple of points to mention. This is Carol Bennett, who's the CEO of Pain Australia. She lives in Canberra and has strong links to politicians, so she's proved to be a very effective lobbyist in this setting. She's worked with Pain Australia to deliver a cost of pain report, which has been done by Deloitte Access Economics and funded by Seqirus, interestingly, that shows 15% of Australians with chronic pain, if you define that as lasting 6 months, many of them of working age, and a cost per annum of $73 billion. There's a call in that for GP education and multidisciplinary care. So woven in and around that launch was the development of a national strategic action plan that really is very much a how-to of the national pain strategy. This has been currently endorsed by federal government and the opposition in the lead up to our current election. They've set aside a certain amount of money for pain education and also supported the establishment of a National Advisory Council on Pain in Australia. These are important steps forward. A final word just to finish on regulation. I was hearing at the dinner last night, which was true from the president of the college here in New Zealand, that we do have a complex system in Australia. Adrian and I, as Australians, almost got up and walked out of the room before we realised that every word that he was speaking was actually true. We do have a complicated system. There are opportunities, though, to engage with different parts of the regulatory system if they can integrate nicely together to achieve change. We do have the Medicare Benefits Schedule scheme that looks at item numbers for different aspects of healthcare, and that's currently being reviewed at the moment. So that, I think one of our key issues there, how well do we value talking therapies as opposed to procedural therapies? How well do we support multidisciplinary care? So there are proposals working their way through in that regard. We have the Pharmaceutical Benefits Scheme that looks at whether or not to subsidise medication. Curiously, at the moment, we do subsidise heavily opioid use for chronic non-cancer pain. Should we, is a question I think we could address there. The Therapeutic Goods Administration, also part of the federal oversight, looks at Commonwealth approval of medications and indications for medications. For example, fentanyl patches initially licensed for cancer pain have been extended into chronic non-cancer pain. Should that be the case? Product information, consumer medicine information, recommendations to sponsors about pack size, all to be considered. And then finally, the state health departments, different from the federal bodies, but state health departments can be responsible for various things. Adrian and colleagues in Tasmania have done very well there. They are one of 2 states in Australia that do have real-time monitoring. They've had that for a time. Evidence from the states suggests that just to monitor opioid dose is relatively ineffective. However, if you monitor real-time opioid prescription and tie it to authority, which is what they've done in Tasmania, you make better headway, and they are beginning in Tasmania to downturn the curves that show an rise in opioid prescribing. So, as I mentioned to start with, I think the coal industry needs to change. It needs to get smaller. Same, I believe, from an evidence-based perspective about the opioid industry. Yes, we need opioids in acute pain and cancer pain and palliative care and in addiction practice. We need to shrink the opioid use in chronic non-cancer pain, and I'd like to acknowledge the team that I work with at Newcastle. Thank you.